Man, woman, birth, death, infinity.
Good afternoon, and welcome to the Your Health television program here on AMP's Cable Channel 24 and on the internet at www.ampmedia.org. Join our rotating host and their informative guest live every Monday afternoon at 4 o'clock. The purpose of the Your Health television program is to help get, make, and keep listeners and viewers like you healthy. And now, ladies and gentlemen, on with the program.
Welcome back to Your Health television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and I'm so delighted you could join us this afternoon for my very first guest, the distinguished, talented, board-certified radiologist, Dr. Kristine Leatherberry. Dr. Leatherberry, thanks very much for coming on our program.
Thank you for having me.
Dr. Leatherberry, this topic about breast screening is so important. It's been in the news. A lot of women have confusion about it. It seems like the guidelines are changing. So before we get into that, which I think this is going to be a session where I learn a lot, I'd like to talk a little bit about what it's like to be a radiologist and what the training is like. So tell me about the training to be a radiologist.
Well, the program is a 5-year program after medical school. The first year can be done in a number of different specialties, or you can go straight into a radiology specialization.
And where did you go to medical school?
UT Southwestern in Dallas.
And I see on your resume, Alpha, Omega, Alpha. Very impressive, Dr. Leatherberry. That's the sort of honor society for the medical students with great grades. So you trained in general radiology, and so you can read x-rays and MRIs and et cetera.
That's right.
And then you did a breast radiology fellowship, isn't that correct?
I did.
So tell us what a breast radiology fellowship's all about.
Well, it's subspecialization just in women's imaging targeted directly with breast imaging. So I worked with Phil Evans at UT Southwestern, who's now the head of the American Cancer Society. And I worked for him for just over 6 months before I ended up coming out here to Monterey.
Oh, so you came from your fellowship to Monterey?
I did.
Great. So now you're on the staff at Community Hospital Monterey Peninsula.
Yes.
And I know you also cover the breast center.
I do. I work with Suru at the Breast Care Center.
Excellent. So you provide very specialized breast radiology services for women of this community. Isn't that correct?
I do.
There at the breast center. So I want to learn all about screening mammograms. I want to learn about when should a woman start getting mammograms, who is at high risk, when do you order another test such as an MRI, and why do you use sonogram and ultrasound, and what woman gets a biopsy, et cetera. Okay?
Okay.
So can we start by talking about what a screening mammography is?
Sure. So screening mammography in general is a test that requires 2 different views of the breast. So it's 2 pictures of each breast. And for the woman that's sort of at average risk, like most of us are for breast cancer, screening mammograms should begin at age 40. They should be done yearly, and many studies have been done looking at biannual screening. And if you're going to think about doing it every other year, you should only consider that after the age of 55.
Okay, so I think there's a couple really important things that you mentioned. So the screening guidelines say that every woman at age 40 should have 1 baseline mammogram. Isn't that right?
That's right.
So it's 2 views of each breast. And then thereafter, every year or every other year?
It should be every year, especially between the ages of 40 and 55. And the reason for that is that that younger subset of women has much more aggressive breast cancers. So mammography's been the only test that's been shown to reduce death from breast cancer. And because those women have more aggressive cancers, it really does target them sooner so that you reduce advanced disease and you're ultimately saving lives.
So, Dr. Leatherberry, I just want to emphasize to our audience, so we have good data that indicates that mammograms can actually result in fewer deaths from breast cancer, early diagnosis, and on to early treatment. Now, do we have good data that indicates that?
Excellent data. It is the only proven modality or test shown to reduce death from breast cancer. There is no other.
Excellent. Now, women are concerned, and rightfully so. We're all concerned about the amount of radiation that we're exposed to over a lifetime. Now, what about mammography? Is it a low-level, medium, or high-level exposure to radiation?
That's a great question. Mammography is low level. Anything less than 3 millisieverts is considered low radiation, and mammography is 0.1 millisieverts. So to put that kind of in perspective for what that means, that's about 50 times less than the radiation you get from just living in Monterey every year. An airplane flight, 3 airplane flights in a year would be just over the amount of radiation you're getting from your mammogram. So those are things we do every day that we just don't even think about the radiation exposure that we're getting.
Okay. Well, Dr. Leatherberry, that's very valuable information. Before we go on, let's talk about what is it about a mammogram that can help diagnose breast cancer? Isn't there something about speckled calcifications and a tumor has a very particular appearance in a mammogram, isn't that right? Or a breast cancer?
They do. There's definitely certain things that we're looking for on a mammogram to try to help us find breast cancer. One of the first things always that we're looking for is there a change? So those comparison films or any mammogram somebody's had in the past are invaluable for picking up really subtle findings. In general, most cancers are going to make a mass. If you're talking about a mass, the borders of them tend to be irregular or spiculated. That makes you more concerned. But any mass that shows up on a mammogram that wasn't there previously would indicate that you should do more workup to try to figure out what it is.
Okay. Now, Dr. Leatherberry, I think we ought to mention that there's a new type of mammogram using digital technology, isn't that correct? Do we have digital technology?
We do. We are completely digital at our breast cancer center, and most centers across the country are becoming digital, and that's really based off of additional studies that showed for women with what are called dense breasts, that means they have a lot of glandular tissue in their breasts and not a lot of fat, that it is more sensitive in finding cancers than film screen was.
Okay, so that's important information. So here at the Breast Center in Monterey, you offer digital mammography, and that's been demonstrated to be a more sensitive test.
It is.
Okay, so I think what we've talked about so far is for the woman with average risk who doesn't have a very strong family history of breast cancer. What about the woman with a very strong history of breast cancer in her family? Let's say her mother, her grandmother, a couple of her aunts, maybe her sister, multiple female relatives directly related to her have had breast cancer. Now, what about screening that particular patient, that particular woman who has a very high incidence in her family?
We need to be more diligent about screening those people. There's also many tests that have been done looking at that as well, and the most sensitive, sort of cost-effective way of screening people that are considered high risk, which means that their lifetime risk of getting cancer is equal to or greater than 20%. And there's several models out there that help you know what your real lifetime risk is.
Okay, Dr. Leatherberry, I just want to interrupt for one moment. So that's 20%. That means 1 in 5 women in that high risk group will develop a breast cancer. That's a lot.
Right.
1 in 5.
Right.
Okay, so excuse me for interrupting. So for that high risk group, you're more diligent, she's screened more often, isn't that correct?
Where you're doing mammography combined with MRI imaging, and that together has been shown to be the way to screen that subset of individuals where their risk is really that high.
Okay, so that's a perfect segue to my next question.
Mm-hmm.
Besides mammography, you offer different types of tests to work up the breast tissue, right?
We do.
There's MRI, and then if we have time, I want to talk about a sonogram or ultrasound. So why do we do MRIs for the breast?
Well, currently we use MRI imaging in a screening setting for those high-risk patients. Some of those patients themselves have had breast cancer. Maybe it's their family history. It could be a bunch of different combined factors that put their risk that high. We're also using MRI today in women that are diagnosed with either atypical cells in their breast when they've had a biopsy, or they've been diagnosed with cancer that hasn't invaded into the breast yet. And it doesn't have calcium, so it doesn't have findings we can necessarily see on a mammogram to try to see, is there anything else in those breasts? So we really use it to try to help establish what is the extent of the disease, how much cancer is in the breast, when you've already done other tests to show that the woman does have cancer.
Okay, that's very valuable information. Dr. Leatherberry, can we teach our audience what is it about calcifications that go along with a cancerous lump in the breast?
Well, we do know that even if we can't see it, that all cancer sort of begins as early cancer that hasn't invaded in the breast. It begins in that duct of the breast or in the lobule of the breast. And I always describe to my patients that it's kind of like a flower. So you've got the flowers, the lobule, and the duct is the stem, just in trying to describe it. And most of the cancers are going to be in that stem or that duct.
So that's what we call intraductal.
Intraductal.
Or intralobular, right?
Carcinomas.
Carcinoma. So it doesn't mean that it's invaded into the breast tissue. It's the early stages are it's found within the duct or within the lobule.
That's right.
That's a great time to diagnose it, right?
It's great. And we know that sometimes those early cancers make calcium. I'm going to say the majority of the time they probably don't, but we're looking for those times that they do. And the kinds of calcifications that they make, they tend to be grouped together, really clustered together, powdery, sort of irregular looking, and they can be new or they're changing and growing. There's many reasons that women have calcifications in their breast that are not cancer. So that's always our challenge in trying to look for those new calcifications, the changing calcifications, to say, I should biopsy those.
Perfect, which is also a great segue to my next question. We teach women and we encourage women, I certainly as a plastic surgeon in my office, for a woman who has breast implants, or even if she doesn't have breast implants, I try to convey the importance of self-breast exams, or see your doctor, your primary care doctor, whether it's your internist or family doctor or OBGYN doctor, and get examined regularly. But I think it's important to emphasize to women that certainly not every breast lump means a woman has breast cancer. Isn't that correct?
That's very true. Sometimes just the way that the regular fat and glandular part of the breast sort of come together can feel like a lump, and it's just all normal things. And then there's many non-cancerous things that can make lumps in the breast as well.
Okay, and I also think it's important to emphasize to women when we talk about screening and self-breast exams, the goal here is to identify breast cancer when it's early. Isn't that correct?
That's right.
Because it's curable.
Right.
And I think, don't we have good data to indicate that if we diagnose a breast cancer early, there's a higher likelihood of an actual cure?
That is true. And that's the whole goal of mammography in general. Your goal is to find it before you can feel it.
Okay. Now, what about the woman that has already been diagnosed with breast cancer? Let's say she's had a biopsy and or lumpectomy or mastectomy and reconstruction. Isn't it important for that woman to be followed as well?
We do. Some people who have undergone mastectomy still have enough tissue left in the breast that we're actually able to image them mammographically. Other women do not. They've had reconstruction and you can't. So with those women, it goes back to, a physical exam or an exam by their physician and possibly ultrasound.
Perfect. Tell us about ultrasound in the diagnosis and screening of breast cancer.
I would love to. So whether something is a cancer or a not cancer that we see on a mammogram, it tends to be white. If we see a mass, that mass is white on a mammogram.
Excuse me.
And we can't tell as mammographers if that's going to be liquid or is it going to be solid. So we use the ultrasound to help us know that. And when we're looking with the ultrasound, if something's a cyst, that's basically, we describe it just sort of as a pocket of water, a pocket of fluid. It's nothing to worry about, just kind of a way that a good number of women hold on to water in their breasts. It has to be perfectly round, it's going to be black inside, and it's going to let the sound kind of go through so it's bright behind. We know those are nothing to worry about, and we can tell them with 100% certainty that they're nothing to worry about. Other things, if they're gray on ultrasound on the inside or their edges are irregular, those are solid and they become more concerning. And based on what those look like on ultrasound, we would probably biopsy that.
Okay, so I remember, Dr. Leatherberry, it hasn't been that long ago that a woman with a breast lump would go to the operating room, not even knowing whether or not she has breast cancer or not. And there was no discussion about breast reconstruction. She didn't even know whether or not she was going to wake up with a breast. Now, we can beforehand can't you pass a very fine needle, get some cells and determine what's going on with that breast lump, and then sit down with a woman ahead of time as a team and talk to her and counsel her about her options. Isn't that correct?
That is. Whether we bring the person back from their screening mammogram or they come in feeling a lump, when we look, if it needs a biopsy, we just go ahead and offer that biopsy that day, or they come back. We take a few little samples of tissue, and the pathologists usually give us the results in 24 hours. So we're then able to turn right back around and tell the person in a very short period of time what we're dealing with and get them connected with a surgeon and in discussions with their primary doctor about where to go from here.
Well, Dr. Leatherberry, that's a huge advance to be able to tell a woman within 24 hours, or roughly 24 hours, after passing a very fine needle into a lump, really what's going on. I think that's a huge advance. We've only got about 90 more seconds. I want to make sure that I give out the phone number of the breast center here in Monterey, 831-622-2760.
That's right.
Right? And you are Dr. Kristine Leatherberry. You're a board-certified radiologist.
Yeah.
And you've done a fellowship in breast radiology.
I did.
In about the minute we have left, let's talk a little bit about the mechanics of a mammogram, and if we have time, an MRI. How long does it take? Is it covered by insurance? And another important question is, does a woman need a referral from another doctor, or can they just simply call and make an appointment?
That's a great question. The screening mammograms are usually covered by all insurance companies. Any woman that needs help or assistance to get a screening mammogram, we have programs through Community Hospital to assist with that. We want every woman to be able to come in and get screened.
Great. And how long does it take to get a mammogram?
It's a very quick procedure, but it's often dictated by the patient as well. So I'm going to say on average 15 minutes to come in and get those 2 views of each breast. But we always have a technologist assigned to a person that will take as long as it takes to get those good pictures.
Okay, so Dr. Leatherberry, my final question is, if a woman wants to have a mammogram, can she call directly, or does she need a referral from her doctor, otherwise, outside of the facility?
We like them to have a referral from their doctor. And a lot of that just alludes back to what you were saying earlier, that it's great if a physician's examined them before they come. And then that way you know if they actually had a finding or a physical finding, it would no longer would be a screening mammogram. It would be a diagnostic mammogram where we could work up that finding.
Okay. Dr. Leatherberry, it's been great to have you as a guest. I've learned a lot. You provide a hugely valuable service to our community, and we all appreciate it. Thanks so much. I'm going to give out the number one more time. Dr. Kristine Leatherberry, 831-622-2760. That's the Breast Center of Monterey.
It is.
Thanks so much for being here. This is Your Health Television Program. I'm Dr. David Morwood. I'm a board-certified plastic surgeon. We're going to take a very brief pause for a very good cause.
We'll be right back with more of the Your Health television program here on AMP's Cable Channel 24 and on the internet at ampmedia.org.